All right, welcome to Caffeine, Nicotine, and Cannabis. Hey, I'm Dr. Audrey Robinson. I'll be your guide along this presentation. All right, so I want to start this with the why. If you are watching this for part of your class, then you know there are counseling classes devoted specifically to substance use and substance use disorders. So why are we even talking about some of these things? I talk about this in every lecture, our why. Why in the Psychopharmacology class are we talking about coffee, cigarettes, and weed? You may have clients who use these and may seek your help to change something about their intake of these substances. To do this effectively and to gain your client's phenomenological world, you need to know how these things work. You need to know what they might be going through and what works and what doesn't for them. All right, so let's talk about caffeine, the most widely consumed psychoactive drug in the world and my drug of choice. All right, let's talk about the pharmacokinetics of caffeine. It's orally, rapidly, and completely absorbed. It's water and oil soluble, which means it goes into our body and brain and crosses the placental barrier. It has a half-life of 2.5 to 10 hours, and some of this depends on different medications taken. It's extended by alcohol, oral contraceptives, pregnancy. It's extended, the half-life is extended in elderly or those with chronic liver disease. The half-life is shortened by smoking until smoking is stopped. Then it may increase with withdrawal. The pharmacology, there's several varieties of the gene that controls the metabolic enzyme. And so you might have a fast metabolism of caffeine or a slow metabolism of caffeine, depending on which gene you have. Slow metabolizers have possible increased risk of heart attack and hypertension, whereas the fast metabolizers have decreased risk of heart attack and hypertension. My father-in-law, as an anecdote, has lots of heart issues, and his doctor, he's had several heart attacks and even an aortic aneurysm, and his doctor has said a couple of different times that the amount of coffee he drinks, because he has this fast metabolism gene, has saved his life. So it kind of depends on your genes, though. It blocks all subtypes of adenosine receptors, which is a neuromodulator that influences the release of neurotransmitters in the central nervous system. And so caffeine starts to take effect between 15 to 20 minutes of the start, and then 45 minutes in, it hits that full caffeine, and just talking about this makes me want another cup of coffee. All right, let's talk about the benefits and the adverse effects. 4 to 5 cups possibly reduces risk of death by 12% in men to 16% in women. Cardiovascular benefits with 3 to 5 cups, gastrointestinal glucose metabolism and insulin secretion with caffeine, possible reduce of cancer with 3 to 6 cups. It can reduce. For neurological benefits, it has some benefits for Parkinson's and MS. With cognitive and mental health, it's shown to have some benefits for Alzheimer's and memory, ADHD. In fact, in one study shown that in half of all people who have an ADHD diagnosis, caffeine works to kind of help them focus. My husband being one of those, he used to drink Dr. Pepper like it was going out of style, drink it all day long, but then of course we know that that's not great for his health, so he switched to unsweet tea and has lots of less sugar in his life, but still needs that caffeine. Really helps him focus. That's why, while it sounds counterintuitive, a lot of people in school systems will send Mountain Dew, because it's a more highly caffeinated soda, to school for their kids to drink at lunch because of the focusing effects. In women, 2 to 4 cups have a 15 to 20% decreased risk for depression. Other benefits would be bronchial relaxation, increased urine output. That might not be a good thing. I don't have to go pee all day long 7 times a day, but I'm going to drink my coffee. And also less erectile dysfunction with 2 to 3 cups. When it's talking over here about the cancer, the 3 to 6 cups that it can reduce, it's talking about endometrial, prostate, head and neck, basal cell carcinoma, colon, estrogen receptor negative breast cancer. Lots of different kinds. All right, now let's talk about adverse effects. And increase or cause anxiety, tremors, rapid breathing, insomnia. I know I can't drink caffeine past a certain time in the day or I'm going to stay up late. Hypertension, cardiac arrhythmias, gastrointestinal disturbances, that's putting it mildly. Caffeineism, which is the overuse or overdose, or can be in conjunction with certain SSRIs, which would be like fluoxetine and fluvoxamine. It can have an effect on sleep. Caffeine and alcohol leads to risky behavior. You've got two different things working in two different directions. Risk of fetal growth restriction and miscarriage, although we don't know a ton about caffeine use in pregnant women and on the baby. And the DSM-5 even has a caffeine use disorder in it. People become tolerant of many of the effects of caffeine, and so once they keep drinking it, some of those side effects decrease. All right, now let's talk about nicotine. All right, let's talk about the pharmacokinetics of nicotine. Absorbed from every side in the body, but only 20 to 25% enters the bloodstream from a cigarette. Works on the CNS and peripheral effects by activating those acetylcholine receptors. We talk about those a lot. Low doses stimulate, high doses block. So depending on how much we take can depend if it's stimulating or blocking. That's kind of the paradox that is nicotine. Many cigarettes have menthol. It masks the harshness of the smoke and even more receptors for nicotine and are less likely to quit higher relapse when the cigarettes have menthol. Pharmacology, with the brain, increased reward via dopamine system, reduced likelihood of Parkinson's. That is a good thing. 40 to 50% of all cigarettes consumed by individuals with mental disorders. So you can see the comorbidity there. Risk for developing schizophrenia and panic attacks. Increased risk of tobacco-related mortality for those with schizophrenia, bipolar disorder, or depression. I have an uncle who, a late uncle who had schizophrenia and was a chronic smoker, both before and after the diagnosis. In the body, it increases blood pressure, heart rate, cardiac contractility, release of epinephrine, and activity of gastrointestinal tract. It can cause angina, heart attack, heart disease, pulmonary disease, and cancer. It can cause nausea and vomiting. And in pregnancy, it reduces the oxygen delivery to the baby. Physiological and psychological dependence. So both our bodies want it and mentally we want it. Withdrawal can cause irritability, anxiety, anger, difficulty concentrating, restlessness, impatience, increased appetite, weight gain, insomnia, and those withdrawal symptoms peak at 24 to 48 hours after cessation of smoking. So when we talk about some of these bad things in here, the cessation of smoking can help reverse many of these. And we also know now that passive smoke is also a threat. All right. Approaches to nicotine. Nicotine replacement therapy, NRT, and then there's non-NRT. The main ones would be bupropion and nortriptyline. So those are partial nicotinic agonists. They are varenicline. Yeah, I'm not saying that right. Suicidal thoughts can also happen. There is a side effect, aggression, depression, and agitation. That varenicline is that Chantix, which there have been lots of studies about. There can be adverse effects, anxiety, tremors, rapid breathing, insomnia, all these different things. Lots of different adverse effects for these. We also know with nicotine, there's the gum, the lozenges, the patches, those are those NRTs. All right, e-cigarettes are a concern, and so here's some resources on that. Vaping and e-cigarettes have become widely used, been in the press. There's so many dangers, including aggressiveness of the bacteria and staph that grow on these. All right, now let's talk about cannabis. My video is not going to play, but you know, if you watch South Park, you maybe remember the school counselor in South Park saying marijuana is bad in K.
Okay, children, let's take our seats. Okay.
All right. So this is a table that comes from the government, and it looks at the trends and statistics for vaping marijuana specifically, and then marijuana use, and the percentages in different grades. And this was kind of staggering and eye-opening to me. And the ones in little parentheses here are clinically significant changes from the previous year. All right, components of a cannabis plant. There's different types of cannabis plants: Cannabis sativa, Cannabis indica, Cannabis ruderalis. And then so you've got these different parts of the cannabis plant: the hashish, the ganja, the marijuana, dabs, which is also butane hash oil, and then CBD. CBD is not psychoactive. And so on here, there's information about what part of the plant it comes from and the content of THC in each one of these. Now, I just before reading this chapter thought these were all interchangeable words, but apparently it comes from different part of the plant. All right, mechanism of action. So the cannabinoid receptors, most abundant in the hippocampus, which affects memory, 1 ganglia, motor coordination, cerebellum, which affects perceptual processing, and frontal cortex, which affects attention. Dopaminergic neurons are responsible for many positive effects of THC, increased in the short term, decreased by chronic use. That's kind of the oxymoron that is cannabis. THC is a partial agonist. CBD does not directly stimulate the receptors, but it is a possible partial antagonist. So as the THC goes up, the CBD goes down, and vice versa. Right, here's a cool little graphic of how these work. All right, we got the endocannabinoid system. Oh, look, they're all popping up. All right, so molecules are naturally produced by cells in the body. Like the plant, cannabinoid THC bind to and activate cannabinoid receptors. It's a hard word to say. Some information about the system: plays a crucial role in maintaining homeostasis in the body. Excuse me, I had to hiccup. Unlike other neurotransmitters, they're made on demand. They also move from the postsynaptic neuron to the presynaptic neuron. Works with precision, impacting only what needs to be addressed. Examples: sweating when you're hot, stomach growling when you're hungry. It also helps regulate all these following systems. All right, so let's talk about the pharmacokinetics and pharmacology. So with cannabis, 1/4 to half of THC available in the smoke is available in the smoke, and absorption depends on inhalation, how long it's held. It's distributed into areas, especially fatty areas, and so they have found that for overweight and obese people who then lose weight, some of those things can be released, but it's mostly the metabolites. Behavioral effects occur almost immediately when smoked, delayed onset when taken orally, which can also lead to overtaking it, because people who take it orally don't think the effects, so they eat more and more of it. Metabolite can stay in the urine for 1 to 21 days, depending on infrequent or chronic smoking, depending on how often. Eating, there's first pass metabolism, which may reduce the THC by up to 2/3, but it will last longer. CBD is not well refined. We don't know much. Most of the information we have is related to smoking. There's not a lot known about the synthetics, and cannabis is such an oxymoron. Many people report becoming sensitized to it rather than tolerant of it. All right, so then the physical: bloodshot eyes, pupil dilation, all these kind of things are typical of these. Cerebral vasoconstriction, sleep disturbances, immunosuppression in chronic users, so might get sick more often, or when they get sick it might be worse. Appetite stimulation before, but then when they're off of it, may feel not hungry. Synthetic THC is used for cancer patients, or specific drug for that. Psychoactive, many individual variables affect this: increased sense of well-being, mild euphoria, relaxation, relief from anxiety. But when it's stopped, there's an increase in anxiety. Psychomotor, there affects coordination, perception, reaction time, and even ability to divide attention. Can affect memory impairment, all stages of memory. Reduction in testosterone can affect menstrual cycles, can affect the fetus, as cannabinoids are present by day 16 of gestation when we talk about the creation of the fetus, and THC crosses the placenta and is present in breast milk. A couple of things to keep in mind. It also can be an analgesic for inflammation and neuropathic pain, may reduce spasticity or the pain from spasticity. I think about like restless leg syndrome or tremors and those kind of things might help with some of the side effects of those. Possible help for epilepsy, neuroprotection, cancers, or glaucoma, but we're still researching that. Withdrawal from cannabis includes irritability, anxiety, craving, disrupted sleep, and strange dreams, anger and aggression, depressed mood, restlessness, decreased appetite, and weight loss. Dependence on cannabis occurs in 1 out of 10 people. Now let's talk about how it comes into effect with psychiatric disorders. With Alzheimer's, CBD in animals reverses cognitive deficits. Not a lot of research for humans yet. For anxiety disorders, especially like PTSD, some states allow it to be prescribed for that. And anxiety correlates positively with cannabis use. So it actually, while we think it might be helpful, in many studies it's shown to not be helpful. It's actually increased anxiety. There's compelling evidence that cannabis is a risk factor for the onset of psychosis, 25% in schizophrenia versus 4% in the general population when use of cannabis. It doesn't necessarily promote psychiatric problems for most, but many may experience increased depression and suicidality. Cannabis preceded the onset of mania for bipolar in recent studies. All right, cannabis use disorder. Just want you to know that that's there, and it is something in the DSM. It has mild, moderate, or severe, and you have to have 2 or more on a list of on the list in the DSM-5 for more than a 12-month period is how it's diagnosed. Let's talk about the treatment of cannabis use. No evidence-based pharmacotherapies proven are proven effective. Things that are ineffective have been proven ineffective are antidepressants, antipsychotics, baclofen. Topamax plus counseling was promising but had very bad side effects, so is not used. Naltrexone, which is an opioid antagonist, can be modestly effective. Gabapentin and NAC, which is N-acetylcysteine, restores normal glutamate activity and has been promising. That one still needs to be researched. Okay, and here's our references. See y'all next time.